video which depicts the different colors of the various states. We have 12 states in all, and the video depicts the culture, the scientific activity of all the 12 states. Mr. Rahul, can you share the video, the ISOC video? Honorable President Dr. Abhijit Ghosh to welcome all the viewers, the speakers, and the special invitees. Dr. Abhijit Ghosh, sir.
Thank you, Pranav. It is always a great pleasure to be a part of this wonderful, vibrant program, we would say. By now, everyone has understood that ISOC is really vibrant now under your able guidance. It's a wonderful program, and the subject which you have chosen today is marvelous. It's definitely a wow effect everywhere. Astigmatism management with Toric IOLS. It's a wonderful subject. As you all know, this program intends to showcase basically the youth of ISOC so that they can interact with all the senior people around the country, which would give them a wonderful platform. So I think this is going very nicely, and we should go. And as you have already said, we have our scientific chairman, Dr. Devashish Das. He has undergone a cholecystectomy today. He's doing fine. So in his place, I think Sugato is there. Let us not waste our time in lectures. I would, Pranav, would you please proceed with your program? Thank you.
Sir, before that, sir, I would also request you are the chairman of the organizing committee of All India Ophthalmic Congress to be held in Kolkata later down the year, sir, in June. So a few words about that also, that will go a long way in motivating members to attend and make it a grand success, sir. Please, sir.
I have forgotten one thing, to welcome Dr. Titiyal and Namrata for coming. Thank you very much. We would also, I think, felicitate Satyabhama Devi, who is a very senior faculty. Thank you, ma'am. Thank you much. And regarding the AIOC, Namrata, she is the boss. She is guiding us very nicely, I would say. She has a very difficult job to do, I must assume. But still now, as it stands, it is a physical conference. We are taking a call. The main thing, there are many problems, but still now, I think about 2,000 delegates have been coming there, and Namrata knows about 70% of the senior traders and 50% of the junior traders have come in. But still, everything is still in a dilemma. We will take a call. I will tell you, the first consideration which you are taking is the safety of everyone. So we are setting up a SOP for the safety protocol, which we will circulate possibly to everyone. Your safety is our main concern. So till now, we are very optimistic. We will take a call later. Namrata can tell you. So let us hope for the best. We are all gearing up to see everyone each other, but you can't do anything about nature. You cannot do anything about it. So let's be very optimistic and go ahead. Thank you.
So with all the promising words, few words from the Secretariat, sir. We are meeting for the 10th time during COVID period, sir. And by rotation, we have been taking up every state, and we have completed the entire circle. We have all in all 12 states in the ISOC group, and this webinar is being conducted by the Northeast states. So we have taken an entire circle. We have taken into consideration all the states, and the second round is going to start with Assam in the next webinar, sir. So today's topic is extremely close to my heart. And I firmly believe that Toric IOLS is the advancement of the decade in cataract surgery. The best angle is that it can be adopted by everyone, and the expenses involved, if you go with the basics, which has got fantastic results, is bare minimal. With whatever equipment you have in your OT, you don't have to change much, don't have to spend much. So this is the best part, the most beautiful part of it. So we are going to discuss about this on this topic. And before we move on the proper talks, there are a few announcements to make. Let us all take COVID seriously and all the process. Yesterday we had around 1 lakh, and we have cards down. ISOC MidCon, which was supposed to be held in May be held on a virtual platform. We had planned a physical form, but we are planning that it might go the virtual way. And I appeal to all the ISOC members to make the All India Conference, which is going to be held in Kolkata, a grand success by attending it physically. And let us all participate in the All India Ophthalmic Society reforms bid that has been undertaken. And I'll request everybody to participate. And with these few words, I'm looking forward to a crystal clear 2020 vision and become wiser with today's talks. We move on with a brief discussion by the Chairman Scientific Committee. Dr. Devashish Das is the Chairman Scientific Committee, but fortunately, he underwent a successful lap chole surgery today for gallstones, and he'll be released tomorrow. So on his behalf, we have today Dr. Sugato Paul, who is the Chairman Scientific Committee of OSWB. He will present his presentation on his behalf. Dr. Sugato Paul, please.
Yes, good evening, everyone. Just give me a few seconds to share my screen.
Yeah, sure.
Is my screen visible there?
Not yet. But you started sharing it, it's not visible. Now it's visible.
Yeah, good evening. So what I'll be talking about is Dr. Devashish Das' vision about the opportunity of the Eastern India's ophthalmologists to work together, to mingle together, and progress together. Now, the Voice of the East is more than just news. We are now organizing fortnightly evening online programs, and it has been fixed on Wednesday evenings. Voice of the East, actually, we will be having alternate 2 academic programs followed by 1 secretarial program, as being said by Dr. Ranjan. Now, the responsibility of the academic program will be given to 1 state at a time, and it will be according to the alphabetical order. And the state in charge of the academic program will put their main thrust on younger generation. So we have to put our main thrust on the younger generation to give them a platform to flourish, than onto the established speakers and academicians. The state organizing the academic program will keep half of the speakers from their state, like today, and the remaining half from other respective states, or it may be guest speakers. And we are also planning to have debate and quiz along with didactic lectures in future programs. It started with Dr. Sudeep Sinha's talk on mind-boosting workshop, Eyes of the Mind, and then we had other programs from Assam, from Bihar, then Jharkhand, Orissa, from West Bengal. Last one was from West Bengal on flags. And today we have our program, as we have already said, on Toric IOLS. I believe it will be a very enlightening program, and we will go back home with some new take-home messages. Also, what we have started is a felicitating senior members of the host state. And initially, we have felicitated advisors of the respective state. Last time, we felicitated Dr. Pannalal Shaha, and today it is our honor to felicitate Dr. Satyabhama Devi. With this, I hand over to Dr. Pranab Ranjan sir to take over the meeting along with the felicitation. Then we can start the scientific program. Thank you so much.
Thank you, Dr. Sugato.
Let me unshare the screen.
Yeah, please.
Yeah.
So we move on to the felicitation part. As already mentioned by Dr. Sugato, we have been felicitating the icons of IZOC, the icons who have made IZOC what it is today. And today we are going to felicitate Dr. M. Satyabhama Devi. I'm just going to share a few facts about her. So, Professor Satyabhama Devi, she was born on 17 June 1952, did her undergraduation from Guwahati Medical College, Assam, joined the services as registrar in the Regional Institute of Medical Sciences, known as RIMS, Imphal, in April 1977, became professor in 2010, and then head of the Department of Ophthalmology in 2012 in the same institute. She superannuated from service in 2017. She is a life member of IZOC, Equine, and All India Ophthalmic Society. So it's a great honor for IZOC. It's a great honor for all the office bearers. And on behalf of office bearers and the President IZOC, I'll request our President, sir, to present this bouquet of roses to her and to invite her to speak, to tell us about her journey in IZOC. Abhijit Das, sir.
Madam, I should call you Didi, I suppose. Please accept my best wishes and regards to you. Thank you for all you have done for us and will be doing for the future also. Madam, thank you so much. I would request you to say some kind words for us, please, madam.
Thank you for inviting me. Good evening, everybody. I am very much happy to be with you this evening. Thank you for felicitating me in this occasion. Really, ISOC is the platform for exchange of knowledge. So I am associated with ISOC since 1985. That is the beginning of my association with ISOC, because there was one professor, now he's no more, Professor M. Lala Singh. He's my teacher also. That time in 1985, one conference was held at RIMS. I was there running after him. We were all the junior staffs. And since then, it has been with me, with all of us at Manipur also, is ISOC. Now ISOC has come up to this level, and it will go up, it will grow up higher and higher, and I think it will fly all over the world also. So with this word, I thank all my members of the ISOC, then members of the executive committee meeting, and then the special thanks to my colleague B.N. Gupta, and also Secretary Pranab Ranjan. Thank you all. Once again, I thank you others all.
Thank you, ma'am. Thank you so much. We
Thank
are
you.
grateful. We are obliged.
By your presence, ma'am. And before I hand over the screen to for the scientific deliberations on behalf of ISOC and on behalf of our Honorable President, I express my deep gratitude to the two special invitees, Professor Titiyal sir and Dr. Namrata Sharma madam. And with this, may I request Dr. Natung to please take over the scientific session. Dr. Natung, Professor Natung.
Okay, thank you so much, sir. And good evening to all of you, especially our special invitee, Professor Jeevan Titiyal sir and Professor Namrata madam. They are my teachers, to those who don't know about me. So I welcome you all. I hope we all have a very good and interactive evening. So since a few minutes have been lost in the introduction part, I'll just say a few words about each discussants. We have Dr. Lobsang Setim. I think he hasn't joined till now, some network problem. So he's a consultant working in Ramakrishna Mission Hospital in Itanagar. And then we have Dr. Anurag Misra. He's director of Radha Raman Hospital, Cuttack, and Car Vision Eye Hospital. So because there is a paucity of time, I'll just speak only one or two sentences. Then we have Sachindra Laisram. He's known to me. He was also an RPC product, and he's working as a consultant in Manipur. Then we have Dr. R.C. Sir has not joined till now. He's a consultant at Susrud Eye Hospital, Kolkata. Then we have Dr. Harsha Bhattacharya. Sir, he's a consultant at SSN Guwahati. He's the president there. And we have Dr. Saurav Sharma. He's consultant at Vasundhara Netralaya, Kamrup, Assam. Sorry, I forgot to tell about Dr. Bharthi Kashyap. She is a refractive surgeon at Kashyap Memorial Eye Hospital in Ranchi, Jharkhand. So with this, we'll invite all the speakers, and speakers will be introduced. Each speaker will be introduced by the moderators. So I'll request Madam Jennifer to introduce the first speaker, please, because Dr. Roy is not there.
And before Jennifer ma'am introduces the speakers, can I have a word about, 2 words about our chief coordinator today, Professor Danay Natung?
Yes, sir.
Yeah, I didn't know him from beforehand, but this was the first time I really interacted with him. He's the professor and head of the Department of North Eastern India at the Regional Institute of Health and Medical Sciences in Shillong, and is a very vibrant and active. And I was really impressed by the momentum, the amount of energy that he put in and bring this conference to this level. And this is the brief introduction of our chief coordinator of today.
Thank you, sir. Thank you. Madam, please. Dr. Jennifer, madam, can you hear me?
Yes, I just, you know, can you hear me?
Yeah,
Yes.
yes, sir.
Yes. So the first speaker, I think, is Dr. Amarenda Deka. He is a very well-known surgeon in Shillong, a very young and dynamic surgeon. And he is from Mission Naturalia, Shillong, Meghalaya. So please, you can start with your topic.
Thank you, madam. Actually, I think I am having some problem. I'm trying to share my screen, but somehow.
Please go to the share screen.
It's not responding. I have been trying for quite a long time. No, I am doing that only, but it's showing like open system preference, security, distinct, then open system preference. And now nothing is coming.
I think he can minimize the Zoom screen, open the document, and then open up the Zoom again, and then share.
Pranav sir from Entod, anyone can help? From
Yeah, Mr. Rahul Jan is there. He's doing it. Mr. Rahul, please help him.
Yeah, I have pressed share button, then it's showing desktop and all. Then I press share, but yeah, I have done that. Yeah, I have done that. Now it's showing like this thing, PowerPoint, this thing, nothing. I have done that. Then desktop option is there. It's already showing blue color. Yeah, I have done that. I think we should go ahead with the next presentation.
Yeah, you can go ahead with the presentation.
Okay. Okay. So meanwhile he fixes. Yes, Madam Jennifer.
So can we take the next presentation? It is by Dr. Pranita Sahay, a very, very young, and really she has achieved so much in a very short time. She has done her MD ophthalmology from RP Center AIIMS and also senior residency from there. And currently she's working as assistant professor in UCMS, New Delhi. And we have seen that she, in a very short time, she has done a lot. And over to you, Doctor, for your presentation.
Thank you, Dr. Jennifer, for the description. And good evening, everyone. At the outset, I would first like to thank ISOC for this opportunity to present on this platform. And before I begin my presentation, I would like to first thank my mentors, Professor Titiyal and Professor Namrata, because of whom I've had the exposure to right from the basics to the most advanced imaging systems for Toric IOL, because of which I'll be presenting all that in these subsequent slides. So good evening, everyone. I'll be presenting on the marking of eye and Toric IOL placement. So Toric IOL outcomes are very crucial for any patient that we do, and a preoperative calculation error or a faulty marking technique or misalignment of the IOL can often lead to an unhappy patient, which can be extremely distressful for the surgeon performing the surgery. So in this presentation, I'll be discussing upon the faulty marking techniques and the appropriate techniques to avoid misalignment of Toric IOLs. So one of the most important concepts is cyclotorsion that needs to be understood before proceeding on to eye marking techniques. It is well known that there is a variation in the eye torsion from sitting to supine position, which varies from 1 degree to 28 degree, with intorsion being more common compared to ex-cyclotorsion, and the torsional changes being more common when surgeries are performed in topical anesthesia compared to peribulbar blocks. So there are various marking techniques which can be broadly classified into the manual marking, the image guiding system, and the intraoperative abrometer. In the subsequent slides, I'll be taking you through to the most of these techniques of toric IOL marking. So the two important axes that needs to be marked and understood for toric IOLs are the reference axis and the target axis. The reference axis is the mark at 3, 6, and 9 o'clock position. Some prefer only the horizontal axis marking, that is the 3 and 9 o'clock, or only the 6 o'clock axis marking. The target axis is the axis at which the IOL is to be implanted and is based on the preoperative keratometric calculation and usually corresponds to the steep keratometry of the patient. So coming on to the manual marking of toric IOL, there are few steps that need to be, few steps that are common to all manual toric IOL marking techniques. First is the application of topical anesthesia, usually proparacaine is used. Second is drying of the ocular surface to avoid smudging of the marks that are being applied on the eye. Third is an absolute erect posture of the patient with the head lying against a flat surface, usually the wall. And the patient should be asked to look in a straight ahead gaze with the fixation target given to the patient that is at the same level as that of the patient's eye, so that the patient looks in a straight ahead gaze. So the bubble marker is one of the most commonly used marker for toric, for the reference axis marking of the patient. The Nugent-Sullivan toric marker consists of a central liquid column on which there is a bubble. The central liquid column is divided into 3 compartments with 2 vertical axes, as you can see in this image. And this acts as a guide for the alignment of the bubble into the central compartment, which ensures that your bubble marker is absolutely horizontal when you are putting on the marks onto the patient's eye, so as to avoid any misalignment. So these bubble markers usually have 3 axes, that is the 3, 6, and 9, which can be painted upon with the help of a marking pen, and that the impression of that paint is placed on the patient's eye. This is a short video showing the toric marking with a bubble marker. You can see the patient is in erect posture and a topical anesthesia has been applied. Now the surface is being dried, and here the bubble marker is being adjusted now till the point that you can see the bubble is right into the central compartment of this liquid column. And just when you're sure that the bubble is in the center of this liquid column, an impression of this mark is applied onto the patient's eye to obtain a perfect mark of the 3, 6, and 9 o'clock position. However, a bubble marker may not always be available for everyone's use, but a slit lamp is definitely available for all ophthalmologists. And again, in this, after applying topical anesthesia, the patient's head and chin is placed on the slit lamp. Here it is important that the patient's head should be absolutely erect and there should be no tilt of head, so that there is no misalignment of the 3 and 9 o'clock positioning. And after you are sure that the head is in absolute erect position, the slit beam of the slit lamp is oriented in a horizontal axis, the beam width being kept at the lowest, and the 3 and 9 o'clock position are being marked with the marking pen. Some slit lamps have a beam length of 14 mm, wherein you don't need to shift the slit beam. But if the maximum height of the slit beam is around 12 mm, which is commonly available in most of the slit lamps, then you may need to slightly shift the slit beam to mark the 9 o'clock or the 3 o'clock axis. Sometimes marking with the pen may lead to a thick or a broad mark. This problem can be avoided on the slit lamp marking by use of a 26 gauge needle, wherein a very precise mark can be obtained with the help of this bent 26 gauge needle, which has been painted upon with a marking pen. After the reference axis is marked, the next important step is the marking of the target axis with the help of a Mendes ring, which is the most commonly used ring in toric IOL placement. Here, 4 aspects are important while marking the patient's eye with the Mendes ring. As you can see, first of all, the surface needs to be dry, because if the surface is wet, what happens is your ink marks may smudge. The second important step is alignment of your Mendes ring. The Mendes ring needs to be aligned, absolutely aligned with your limbus, because any misalignment or decentration of the ring on the cornea may lead to decentered marking of your target axis or the reference or its alignment with the reference axis. The third important step is the alignment of the 0 and 180 of the Mendes ring with the reference axis that you have marked pre-operatively. So the 0 and 180 degree of the Mendes ring should be absolutely aligned with the pre-operative reference marking. And the fourth important thing is where to place your 0 and 180 degree. So it is important to understand that the 0 degree is always temporal in the left eye and nasal in the right eye. The 0 to 180 degree rotation is in the anti-clockwise direction for either eye that you are operating. After you're sure that all these steps have been appropriately taken care of, the target axis can be marked with the help of the target axis marking guide. The target axis is marked here with the target axis marking guide, here it being 160 degree. And sometimes the mark obtained with this can be a little thick. So sometimes a Sinskey hook can also be used to obtain a precise marking for the precise marking of the target axis. There are certain limitations of manual marking techniques, that is smudging of the dye, irregular marks, broad marks, fading of the mark. It can be sometimes uncomfortable for the patient, and it is difficult to perform in an uncooperative patient, and it has a significant learning curve. So with these limitations in mind, the image guided marking system was developed, of which the Callisto IN Z-Align system is one of the commonly used system, which is produced by the Carl Zeiss Meditech system. And it takes in the IOL Master 500 or 700 is the machine that is required to capture the pre-operative reference image, which captures the limbal vasculature and matches with the intra-op image of the patient's eye and compensates for the torsion and ultimately gives you an intra-op alignment of the reference axis. It also gives an incision guide, a rexis guide, and ultimately a target axis guide. A similar system is the Virion image guided system produced by the Alcon company. Herein, the reference landmarks that are used are slightly different from that of the Callisto system. It uses the scleral blood vessels, the limbus, and the iris details. And the subsequent steps are similar to that Callisto system. That is, an intra-op image is captured, matched with the reference image, and gives you a guide for the reference axis, target axis, and the rexis guide. The advantages over the manual marking is that an additional guide for corneal incision and a guide for a rexis and guide for IOL centration, live guide for IOL centration is provided with these image guided systems. This is a short surgical video which shows the use of Callisto system for the toric IOL placement. So you can see the intra-op image is captured and matched with the reference image, and it is giving you the yellow and blue lines. The yellow line shows you the reference axis, that is the 3 and 9 o'clock alignment, and the triple blue lines are used for the alignment of the alignment of the IOL, that is the target axis. So you can see that these lines are visible to the surgeon in the oculus of the microscope during the surgery live. There is an additional yellow line that you can see at the limbus, which is a guide for the incision. It is very important that the incision is appropriately placed, because a deviation in the incision from what has been planned during the toric IOL calculation can alter the postoperative astigmatic outcomes and also the patient's vision. For example, if you have entered 20 degree as your incision axis in your toric IOL calculation, a misalignment of the incision from what has been entered pre-operatively can also alter your post-operative astigmatic outcome. So one of this advantage comes with the Callisto system. It is giving you a live guide for your incision alignment. The next important thing that we discussed was the guide for the capsulorhexis. So an absolutely circular central capsulorhexis is very essential for toric IOL alignment, so that it allows, there is no, because if your rexis is well centered and circular and covering your IOL in all directions, then there is less risk of your IOL getting tilted or rotated later on. Next is your IOL alignment. So after the IOL is injected, with the help of a Sinskey hook, the IOL is being aligned. to the target axis. But before proceeding on to the irrigation aspiration system, as you can see in this video, the IOL was left a little misaligned in the anti-clockwise direction by 10 to 20 degrees, which was later aligned after removal of the OVD. Because when you do the irrigation and aspiration of the OVD, some amount of rotation of the IOL is expected to happen, and hence you leave it slightly misaligned prior to the removal of the OVD. And after the OVD has been removed, with the help of the IA probe itself, it can be aligned to the final axis. However, there are certain limitations with these image-guided systems. That is, sometimes repeated disengagement of the eye tracker occurs intraoperatively, which may require repeated registration of the eye. And sometimes there may be difficulty in intraoperative registration of the eye because of conjunctival chemosis, bleeding, or ballooning, or the patient being uncooperative, having a deep-set eye or a narrow palpebral aperture. The third method of toric IOL placement is the intraoperative abrometer, although it is very expensive and not readily available, but one needs to be aware that this system can also be used well for the toric IOL placement. The most commonly used system of the intraoperative abrometers are the Optiwave refractive analysis, also commonly known as ORA, which is based on the tabloid-Moir interferometry principle. It gives a real-time calculation of the IOL power and axis based on the aphakic refraction, and also helps in the axis refinement. This is a short video which is showing after a routine phacoemulsification how an aphakic refraction is captured in this patient's eye. And after capturing the aphakic refraction, you can see that a spherical power is predicted by this machine, and wherein the first myopic power can be selected. And subsequent to this, it will also give you an option of what are the toric IOL series that can be selected and that can lead to least residual refractive error. So, but what is important is for using the system and availability of IOL library, toric IOL library should be there, that all the series and all the spherical powers and all the toric series are available to you, which is often very difficult in a routine setup. So after you select the spherical and the toric series and place the IOL in the patient's eye, you can again capture a pseudophakic refraction in the patient and see if your alignment of the IOL is in perfect alignment to the target axis that was targeted. And in case if it is misaligned, the machine gives you a guide whether it needs to be further rotated to the right or the left to obtain further refinement of your axis. And in the end, if you obtain a no rotation recommendation, that means you have achieved a final target axis alignment and no further rotation is required, and that's the end of the surgery. Another system which is based on the intraoperative abrometry is the Holos intraop abrometer. It works on the same principle as that of the ORA. The limitation, as we've already discussed, there's a high financial cost involved in this, and it occupies a lot of space in the OT. And also some surgeons believe that intraoperative factors like use of the eyelid speculum, presence of corneal edema, and air bubbles, all these can alter the intraoperative refraction and can give a fallacious result of the intraoperative refraction from these machines. And sometimes it may not be able to capture the refraction at all in case there are air bubbles or clumps of dispersed OVD. There is an inadequate intraocular pressure or presence of multiple RK marks. The topic of misalignment of IOL will be discussed by my teacher itself, so I'll not dare touch upon this topic. Coming to the comparative studies. So based on these marking techniques, there have been a lot of research going on to which is the best marking technique, whether manual marking or the image guided system. One of these studies was published by Titiyal et al., wherein the Callisto eye imaging system was compared with the bubble marker, and it was observed that while the visual acuity was comparable with both the marking techniques, but the visual quality was significantly better with the image guided system, image guided surgery group, and this was particularly because the deviation from the target axis of implantation was significantly less in the Callisto eye and Z-align systems. Similar results were observed by Mayer et al. When comparing the Callisto eye system and manual marking techniques. Hence, they conclude that the visual acuity is comparable in both the systems, but if the imaging system can be used for toric IOL alignment, it will give you better results. With that, I'll come to an end to my slides. Thank you.
Yeah, Dr. Pranita, it was a nice, crisp and presentation. I think about everything about the marking has been covered. Uh, the only thing with manual marking is that it takes some time. It takes some getting used to.
Yes.
Like if you have actually gotten used to, like you can safely use the slit lamp or you can use the bubble marker. The thing is that like all everything with manual, like for each and every step, like there's always a chance of error. So like if it is a single step marking, like if you mark the cornea at the slit lamp in a single step, and you can use that marking, you can mark the target axis while sitting on the slit lamp, it reduces the further chances of error. Like for example, if you do a bubble marking pre-operatively and like on the table intraoperatively, you mark it again the target axis. There it becomes two step. So like it increases the chances of error. So like what we actually do is like we try to reduce the number of steps to reduce the amount of error. But otherwise, like if you're using an imaging based system or a aura or any other system, it's very good.
I would like to say something, Dr. Pranita. A very excellent presentation, and there is no point is lacking there. Just I had personal experience while marking manually, though I use Callisto system in my routine practice. If you put eye speculum, it gives very good exposure and very good marking exposure to the eye, and you can better mark always with putting a speculum on while marking. So this is a practical tip which I have been doing before acquiring the Callisto system, and it gives very good results.
Sure, sir.
Okay, thank you very much. Madam, can you call Dr. Amarendra Deka again? Is there?
Dr. Deka, are you ready?
Sir, before that, we just missed out to.
Yeah, Dr. Bharti,
We missed out to welcome the chairpersons of today's webinar, Dr. Biraj Goswami sir, Dr. R.C. Mehra sir, Dr. B.N. Gupta sir, Dr. J.G. Agarwal, Dr. Nagendra Prasad, Dr. Sujay Samanta, Dr. Saraj Bhattacharya, and Dr. Y.C. Mehti. Welcome all of them.
Dr. Natang, I want to add one point.
Yes, yes, please.
Before image guided system, when we used to mark the axis by reference mark by bubble marker, we always used to check the marking error by a Jaldivar caliper, which is there in ITRIS machine, ITRIS barometer. So always we should check it if we have ITRIS, the marking error by Jaldivar caliper. And the other thing is that for intraoperative target axis marking, we use crescent knife. Even when we are using image guided system, we use crescent and then we stain it with trypan blue. It's very sleek.
I would also like to share one thing, because I do a lot of torics and I do manual torics. And what I do it on a slit lamp, use the 26 gauge needle to mark the 3 o'clock and 9 o'clock position. And then on the operation table, put the marking with the help of the Sensky hook. So that the stain remains there. And I do not mark, I just mark the reference marking. The target marking, I do it after doing the phaco and everything. At the end, whatever the target marking has to be done, I put the Mendes after injecting the viscoelastics. Then I put the Mendes ring and then mark the target. Because that fudging and all things which I initially had to face, that I did not face later on. And the results are not that bad. I mean, in the sense, the results are equally good.
Yes,
so I want to ask it.
Yes, I agree with you, sir. I also use this manual marking technique with 26 gauge needle. And yes, Dr. Deka has come. So
yeah, it has opened. So
yeah,
lucky.
Paucity of time, like we will start with the next talk. Yes, please. Go ahead.
Can you hear me?
Yes,
yeah, we can hear you.
Thank God. So first of all, thank you. Good evening, my teachers and my colleague. I am thankful to Professor Natung for giving me this opportunity. The topic of presentation is case selection and preoperative torical calculation. What is toric IOL? As we know, toric IOL is a procedure of choice to correct corneal astigmatism of about 1 diopter or more. It was first introduced in 1992 by Shimizu, and he implanted 3-piece monofocal polymethyl methacrylate implant through 5.7 millimeter incision. Following that, several modifications took place related to material as well as design. As we know, modern cataract surgery is more of a refractive surgery. There was a time few years back, if we can implant a lens without PCR or not much of a corneal damage, means our purpose is done. But today, quality of the surgery mainly depend on quality of vision we provide at the end of the surgery. For myopic and hypermetropic cases, we can give accurate spherical correction by appropriate spherical IOLs. Whereas there is about 20% of patients who undergo cataract surgery has 1.25 diopter of corneal astigmatism or more. And this group of patients require toric IOL implantation. Also, we are aware that every incision on cornea includes additional SIA. So implantation of monofocal IOL in these cases result that uncorrected visual acuity both for distance as well as near. And if we implant bilateral toric IOL in those cases, we can achieve spectacle independence in about 97%. Whereas if someone wants near correction, we can advocate multifocal toric IOLs. This photograph showing the vision of a cataract patient with astigmatism, and second picture is correction with monofocal IOL. You can see that the distant vision is blurry. If we implant toric IOL, he'll have very sharp and distinct vision. What are the requirements for toric IOL implantation? Before going for that, let us discuss few cases. This is one of the case. You can see that both eyes are pseudophakic, and on post-operative refraction, you can see there is spherical correction. So before going for toric IOL, our post-operative spherical correction should be predictable. If patient has to wear spherical correction following cataract surgery, there is no about toric IOL. This is second case. You can see here patient is having significant PSC, and on refraction there was hardly any astigmatism. But when you have done biometry, you can see there is significant astigmatism on the right eye, and this patient will be benefited by toric IOL implantation. In the third case, this is a case of high myopic with astigmatism, and this is ideal candidate for toric IOL. And you can see after implanting toric IOL, patient has achieved 6/6 vision on first postoperative day itself. So how to start toric IOL? Quality of our surgery is very important. When we talk about quality of surgery, it means quality of vision we provide at the end of the surgery. And for that, biometry is very important. I may be a very good surgeon, but if my biometry is not good, I cannot have satisfied or happy patient at the end of the surgery. And after the biometry, most important is correct IOL calculation depending on the formulas, and also it should be customized as far as patient requirement. While talking about the technique, we should always know our own SIA. And also, you should incorporate fast post-operative day uncorrected visual acuity. And we should record it in each and every case because it tells us about the quality of surgery we have performed. And also, we should stress on final uncorrected visual acuity. This patient selection is very important. Initially, we should go for only regular corneal astigmatism with a 1.5 diopter or more. And also, we should select vision compromising cataract, because if we operate on very early cataract, if we go somewhere wrong, then patient will be very unhappy at the end of the surgery. And also, if someone wants spectacle independence, then always we should give option for toric IOL as well as multifocal toric IOLs. Outcome may be influenced by numerous factors, right from the preoperative case selection, investigation to accurate intraoperative alignment and postoperative care. To enhance accuracy of characterometry, it is always advisable to do at least minimum 2 times, or if you have 2 devices, ideally we should do at least with 2 separate devices. So successful outcome depend on good patient selection, preoperative workup, IOL calculation, good surgery with centered IOL. Preoperative workup should include refraction, keratometry, biometry, as well as surgically induced astigmatism. If we have topography to set up, that is very good. And if OCT or B-scan is there, we can also do depending on the grade of the cataract. And it's always advisable to measure corneal endothelium cell if cases are advanced. And marking technique already covered. What is surgically induced astigmatism? As we know, whenever we make any incision on cornea, it causes some amount of astigmatism. If it is towards the limbus, astigmatism is less, whereas if it is towards the cornea, it is more, and also it varies with sizes. So we should know what is our own SI, because total astigmatism should include SI before calculating the IOL power, and also we can calculate our own SI by using software or from website. Biometry is again very important. Axial length measurement should ideally be done with optical biometer, as well as immersion technique also equally good. When we talk about astigmatism, we should only consider corneal astigmatism while calculating IOL power. Various companies provide online calculation software which are very easy. This is one of the online software. Here, what we need to input is patient data, keratometry reading, then IOL, spherical IOL power, SI, as well as incision location. And what will be the output? This software will tell us about IOL recommendation, axis placement, as well as amount of residual astigmatism remain after the procedure. What are the disadvantages? As we know, improper alignment or rotation of IOL after surgery may result in more residual astigmatism than predicted. If there is 1 degree toric IOL axis deviation, it will lead to 3.3% loss of toricity. And if there is 30-degree rotation, that means toricity is gone, and rather it will give additional astigmatism. There are few relative exclusion criteria. Those are irregular astigmatism, post-surgery, post-refractive surgery cases, corneal dystrophies, corneal edema, as well as if there is any complication during the surgeries, ideally we should not implant toric IOLs. And design was basically, there are 2 design, like loop haptic as well as plate haptic. I have used both, but I feel that this for me this loop haptic are more suitable. And before, the material is very important. Before, material was made of silicone. Nowadays it's available in acrylic material, and they usually stick with the capsule, and there is almost no rotation after 2 weeks of implantation. So to summarize, accurate preoperative measurement is very important. Precise biometry, keratometry, and topography will result in the best outcomes for our astigmatic patient. Usually you should use immersion technology, but if it's not available, you can, if it is available, optical biometry system is always good. It's very important to account our own SI. SI impact toric IOL result and must be counted for calculation. And also we should calculate our own SI based on at least 30 cases where incision size and location are known. There are some guidelines if we don't know our SI, but even surgical team, they sometimes help to calculate our own SI. And for spherical equivalent, there are several formulas available, and you should choose the formula as per your experience. Thank you so much.
Thank you, Dr. Deka, for the very excellent and comprehensive presentation. So I guess we have about 47% of patients with cataract with pre-existing astigmatism of more than 1 diopter. Hence, we know that why toric IOLs are to stay. Hence, first and foremost, as Dr. Deka has said, is patient selection. Patient selection is very, very important. And to begin with, we ever always advise that you go with a lower amount of astigmatism, because then if there is rotation also, then the residual astigmatism won't be that much. And as he has said, always go with regular astigmatism. Don't go with irregular astigmatism. And also lens selection is important. Initially, don't go with multifocals, go with monofocals, because if multifocals, if there is slight rotation, then there may be more visual discomfort in the patient, and then you have to even expand the multifocals also. So always go with multifocals. And also, while I think the previous presenter has said that while implanting the IOL, you implant with your own technique, but then you keep it say 5 to 10 degrees less counterclockwise, so that you have, after OVD removal, you can then rotate the IOL. Or else, if you are doing hydroimplantation, then you can keep the IOL at the desired mark. And also, I think first and most important aspect is patient counseling. Patient counseling is very, very important, because you have to know your expectation and also patient's expectation. Hence, I think if you incorporate everything, then I think we will have a happy patient after our Toric IOLs. Thank you.
It's a foregone conclusion that if you want to establish your Toric IOL practice, or for that matter, any ATIOL practice in your setup and make it prolific, then the biometry has to go up, step up a few notches beyond the basic level. So it would be my urge to everybody who's listening in, just to upgrade yourselves from the immersion technique and go on to the optical biometry techniques if you really want to focus on your Toric IOL practice. Beyond selection of patients and just doing a biometry, there are a few cross-check criteria that we must emphasize on. The first of which is, I would not like anybody to take keratometric data from the autorefractometers. Take it from an optical biometer or any machine that measures keratometry proper. You can measure keratometry from two different machines working on two different principles, but never extrapolate the data taken from one machine and feed it to another machine to get your IOL power. That always leads to mistakes. One small point is the keratometry after being taken has to be cross-checked by you. Look at the crosses, look at the dots, look at the points from where the keratometric data has been taken, and make sure that they have been taken properly. A white-to-white dimension also gives you an accurate clue as to how good the evaluation was, how good the examination was by the machine. And if there is a mistake, you can always cross-check. The other thing that is important is, if you have a toricity lying at the corneal plane, and you do have access to the patient's refraction before the cataract started, and it does not show an astigmatism in the power of the glasses that has been prescribed, be very, very wary of it, be very mindful of it, because there could be a lens tilt which is compensating for the corneal toricity. You can cross-check that with the eye trace if you have access to one, with the anterior segment OCT if you have access to one, but these happen in a few patients, you have to be mindful. Would just like to end by mentioning this, that equipments like the eye trace, the Zaldiver's caliper, and the Osh's alignment, they work very well, but they work well if you have a misalignment and you want to align it back to its original position post-operatively. As far as planning a toric and marking is concerned, in my hands at least, they have not worked very well. And the other limitation that the eye trace has, it always takes the wave front case, which are not very ideal when you are planning a toric implant in particular. So it is my appeal to everybody, ladies and gentlemen, get your equipments, set them up in your clinic, practice technology, and do not practice ophthalmology alone. Thank you.
Okay, thank you so much. So without losing much time, I would like to introduce our guest speaker, Professor J.S. Titiyal, sir. I would just give a short introduction. Actually, we all know him. He doesn't need introduction in reality. Sir is a Padma Shri awardee, and he is the professor and head of Cornea, Cataract, and Refractive Surgery Services, and also Chairman National Eye Bank, and he's working at RP Center, my alma mater, for RP Center for Ophthalmic Sciences, AIIMS. Sir, very warm welcome to you. Please start, sir, your talk.
Sorry, nothing. There's something, it's not. I'm not sure what's gone wrong.
Okay, sir.
Let me try again, because it's come now. Okay. Yeah, thank you very much for a kind invitation, and it's my sincere gratitude to entire IJOC team, and my best wishes to entire scientific committee for organizing this wonderful webinar. And we had a nice two initial talks by two speakers, who wonderfully covered the entire gamut of toric IOL techniques and the pre-op assessment. And thank you for giving me this topic. I have been conducting this in Toric IOL instruction course in American Academy for last 3-4 years. One of the most popular instruction course, along with David Chang and Boris Manugin. I would say it is, as rightly pointed out, very important topic. No financial disclosure from my side. My thanks to my two young colleagues, Manpreet Kaur and Sridevi Nair, for helping me in this particular talk. We all know we do have a significant number of patients requiring a toric correction. And the easiest one is to do an intraocular lens implantation with toric power while doing a cataract surgery in these cases. We all know, we just heard from the two speakers, that we do have a better understanding of how to assess the corneal toricity, the power, both anterior and posterior corneal curvature, along with the good biometry, which has been highlighted. The results of toric IOLs has been a wonderful since we had acceptance of these lenses by all surgeons. Now patients also have a good faith on the surgeons for achieving good results with the toric IOLs. And to have post-operative surprise now today's time is very, very uncommon. So there will be very few instances where you require something to be done after toric IOL implantation. As rightly pointed out by Dr. Parinita, the visual acuity results have been wonderful with all types of toric IOLs. And significant rotation is very difficult to see nowadays, unless you have done some mistake in a calculation of your cases. So it is very important to assess uncorrected distance visual acuity if you put a monofocal toric IOLs, or if you put a multifocal IOL, then all distance, near, intermediate should be checked for these patients. So which are those predisposing factors which can lead into a post-op dissatisfaction of patient and the surgeon? So those can be divided into pre-operative, intraoperative, and post-operative. In this regard, I think pre-op assessment is the most important one, which has been highlighted very nicely by Dr. Deka. This is inaccurate IOL power calculation. There are two important aspects in IOL power calculation toric lenses. One is you need to know accurate corneal toricity. That is the power of corneal toricity, which is going to be corrected by the IOL. You don't have to do a refractive toric correction here. We are doing a toric correction for a corneal toricity. And second important thing is to know the exact axis of steeper meridian. Therefore, you need to have, if you are using a two instrumentation, if your steeper axis matches with the two instrumentation, these patients are going to be good for our toric implantation. Other important consideration is the ocular surface. Therefore, whenever you are doing a premium IOL cataract surgery, the first investigation should be biometry for your patient without disrupting the ocular surface. So don't do other investigation before looking for corneal power, or you call the patient next day also. So important thing is to know the axis is accurate. Second important thing is intraoperative surgical wise, we nicely highlighted by Dr. Parinita Sahai, beautifully demonstrated various ways to do intraoperative corrections. And most of the mistakes does happen in that particular area. And the post-op is look for a rotation if patient's visual acuity is not effectively to the patient's satisfaction. The majority of rotation people will appreciate within first 10 days of a surgery. People have documented, Miyake et al., that it can be within the first hour of surgery. But we all don't practice to see our patient within 1 hour of surgery. We normally see them next day, which is, I think, is critical for all of us. So you must see your patients, toric IOL patient in the post-op period, which is going to be very important as such. So sometimes you have a capsular axis which may not be adequately covering the IOL from all areas. You may have a decentered capsular axis, or it may be a torn capsular axis. Or sometimes I've seen IOLs are placed one haptic in the bag, other haptic away from the bag or over their axis. These situation can lead into a post-op rotation or patient not happy with this. This has been highlighted very nicely. Hydrophobic lenses, acrylic lenses, they have the better strength with capsular bag additions, especially with the haptic getting attached to the capsular bag, and they have a lesser rotation. Silicone lenses we don't have now, we don't use them. But if you're looking at acrylic lenses, the open loop haptics is one of the better way of getting a good stability in the bag. What are the other ways to look into? What would be the cause for a rotation in these cases when you have done surgery so perfectly? So one of the important things is incomplete viscoelastic removal. Therefore, if you're using a viscoelastic in these cases, especially methyl cellulose, you do have to take out both from anterior and posterior surface of the IOL. Many people have shifted to hydro injections. And there also you have to be careful because you do use methyl cellulose sometimes in the cartilage. You need to remove that also. The early rotation is mainly because of OBD, or sometimes the lens material is such they don't open effectively during your surgery. Some lenses take even half an hour to open absolutely, like we had in Vista lenses. Late rotation is basically because of a bag or a larger axial length patients or a myopic patient where late rotation can happen. Or sometimes IOL design may be such which will have more incidence of rotation. You can see here, this is a study I've compared. The rotation required in a post-op period is less than 3%. Effectively, now it is hardly 0.5% or less. So that is because we do have a good material, good design, and good surgical technique now. This is Dr. Panita talked about my study where we compared manual versus this thing. But in both groups, you can see that the rotation is less than 6 degrees in both areas. Therefore, you don't require to have a rotation to be done in these cases of toric implantation in today's technique. So anything more than 10-degree rotation post-op, which you have assessed, or visual acuity less than 6/9, you might like to assess these patients for a rotation requiring to correct the remaining astigmatism. So within a 1 week is a good period. Don't wait for too long or don't do too early in cases where you have implanted in correct position. In a post-op, you see there's a rotation. Therefore, there is some sort of a inappropriate alignment of lens with the bag. Either bag is loose or axial is too large. So there you have to wait for some time, maybe 1 or 2 weeks, so the bag becomes more stable in these cases. So basically, IOL rotation is done for those cases where you have a wrong axis you picked up in a post-op period. Otherwise, all other cases where your power axis is all right, then you have to think of other options like piggyback IOL exchange or a laser refractive correction for these patients. Surgically, it's very simple because you can do with, if it's a small degree of rotation, you can just open one side port and take a BSS cannula. You can just tuck it and get a rotation done. Or bimanual rotation is the best way to be done in these cases. Look for an addition which is normally in an optic-haptic junction, or a haptic is normally adherent to the capsular bag. So that has to be released very gently. If needed, you may have to use viscoelastic also sometimes, so that you don't jeopardize the general attachment in these cases. New target axis has to be measured in these cases. So what are the various ways by which we know what is the new axis or new orientation of IOL in these cases? So that can be done by slit lamp after full dilatation with a slit lamp rotational gauge. You can use ray tracing aberrometry, or you can do a retroillumination photographs, which can be captured by various other softwares, which can be ImageJ, or you can use a smartphone in these cases. Then subsequently, you can go to online software to assess or to realign one of these lenses to a proper axis and get appropriate assessment of these cases. So this is what we do. If patient has a reduced visual acuity, uncorrected visual acuity, you perform refraction, subsequently dilate the entire pupil to see these dots and assess where exactly these orientation of these axes is concerned. Don't think of previous axis. Now the new axis is these three dots which are there in these cases. So slit lamp, you have these marking which is a 5 degree apart. So take a small beam and rotate to the axis where 3 dots are aligned. So that will give you the new axis of these lenses. Similarly, you can take a photograph, use these various apps, iToric, Cornea Trans, Tor SE, iPro 2013 Axis Assistant. So with this, you can again take a same picture. This is iToric application developed by our own colleague, Dr. Patwardhan, where you can take a picture with your smartphone, and that gives your smartphone will have a gauge which can give you this alignment. After taking the picture, make sure this circle matches with the limbus and tells you the exact orientation here. If you see here in this particular case, these three dots are at 168 degrees, 170 degrees. The lens was supposed to put at 170. So the 2-degree disagreement. So this is acceptable as such. The same patient of mine, we did an eye trace, which also had a similar picture. So all these apps which are available are also effective enough to give you an accurate analysis of your patient. Second device which people can do effectively is using a smartphone. First, you do direct pupil and take a patient a slit lamp and take rotate your slit beam to an axis where you can align to 3 dots. After you align, take the ask the patient to go back, take your smartphone, and with this app, the smartphone, you come closer to the slit lamp marking. That will give you a new axis of your IOL. So this is simple and everybody can do it as such. Third thing is that this is from Dr. Amar Pujari, where you can take your iPhone, attach with this macro lens with this. This will give you an entire picture of eye from around 3 to 5 centimeter distance. After you've taken the picture, so this is the alignment which is there in the iPhone. That gives you exact alignment to 3 dots and you know exact axis of a lens orientation now. So these are various methods of orientation picked up by these smartphones. This is a retroillumination photograph with your slit lamp or with your smartphone. Then you can take it to image J, and that can give you the axis. So these 3 dots in either side has to be aligned. With this line, you have a new axis or orientation. So these are various ways by which you know that which is a new axis for your IOL now, which is inside the bag. And you take it to image to a online software, which is astigmatismfix.com, which is very commonly used by all of us. That gives you 2 important things. One is how much rotation you require after you have seen the new orientational lens, and how much correction will be there after you rotate this lens in these cases. So this is an example of one of my patients, a 60-year-old male patient, where I have implanted 23 diopter T8, and the post of visual acuity at day 1 was 618. So we did a refraction. Refraction showed 0.5 spherical and 1.5 diopter cylinder at 45 degrees. And with the examination, we knew that the new axis for this patient is 100 degree. It was supposed to be 85 degree. Now it is 100 degree. Once you know these parameters, you feed into this. It tells you that you require a 12 degree rotation. And with 12 degree rotation, your new refraction will be 0.21 cylinder, which is effective correction, and patient will have a good visual acuity. So this tells you new axis, and it also tells you how much effective correction will happen. So this is a very important on-site website where you can assess your toric subsequently. This is another patient of mine, 45 male patient, where you can do refraction showed only spherical power, no very little cylindrical power in these cases. So this patient will not benefit with rotation because it is mainly spherical power. Therefore, the biometry would have been little difficult in this patient. So you know that which patient will help in a rotation. Eye trace, which we do regularly because we had eye trace for last almost a decade or so. That also gives a similar picture. It gives you internal orientation or axis of lens. It gives a toric cylinder of a cornea and tells you how much rotation will be required. And after rotation, what will be the outcome? So once you have a red refraction coming with eye trace, that means the refraction is not appropriate. So this patient required 154 degree rotation because you can't rotate anti-clockwise. So you have to rotate clockwise to 154 degrees to give you a good correction. And this is with the astigmatismfix.com, gives a similar orientation for a same patient. So we had a good outcome in this patient. So this is a patient where it tells you that you require a 74 degree rotation, which will give you a 3.14 dioptric change. So this is a patient, high myopic patient. So I'll wait for at least 2 weeks before I rotate this lens, because if I rotate within the first day, again, lens may go to the same position because the bag will be little distended. So sometimes this is, we use Barrett calculation TK nowadays. So if you have an oblique astigmatism, sometimes your reference axis and the implantation axis are different. If you see here, my implantation axis is 45 degrees, but my reference axis here is 155. If you have that mistake, sometimes you put the lens in a different area. So this is what I had one patient where my resident told me a different way. So I implanted a lens in the axis which is 98 degrees, but actual axis implantation was 178 degrees. So this is within a first post-op day. So rotation will be simpler. I use my bimanual technique. So these are 2 side posts I had made during my surgery. So this is the irrigation on. Try to just nudge the optic haptic junction so that bag is clear. And with the irrigation on, the chamber is well formed, lens bag is well distended, rotation becomes very simple. So I would suggest if you have a rotation to be done more than 15 to 20 degrees, bimanual techniques should be done. If you have rotation required in less than 12 degrees, you can do a single-handed rotation also. So if you have image guided system, the axis orientation becomes much simpler. There's the same patient who required rotation, and post-op he did very well. So there are some patients, it gives you assessment, that patient doesn't require any rotation. So these softwares are useful for assessing your patient appropriately. There are laser refractive laser cataract surgery devices where you have as such, capsular axis with customized tongue-shaped orientation for an axis orientation. So this is a LENSAR system. So if you have this tongue-shaped orientation, this also is a guide in the post-op period, how much rotation your lens has gone through in the post-op period also. To summarize, there are 3 important things. One is a post-op toric alignment is needed. If you have, then you have to do a slit-lamp assessment with a full dilatation. Go to online astigmatismfix.com to assess how much rotation required and what would be your outcome. If you have eye trace like ray tracing system, that will also help you. Toric alignment is very simple in these cases, and which can be done accurately, but you have to know where you have done a mistake. It was pre-op, intra-op, or a post-op period. Management can be done within a week. Don't wait for a too long because fibrosis will be in the entire bag. So once there's always a memory of bag. If you rotate the lens might again go back to the same memory place. So don't let your bag fibers too much. This is a review article for optimizing outcome toric IOL in IGO. People can go through that. So finally, again, I'll say there are 3 steps of a post-op assessment of your toric IOLs. Check your toric IOL alignment first by doing a slit-lamp assessment, retinal emission photograph, or if you have a software with a smartphone app, which is free available with us also. If you have a ray tracing device, use that. Step 2 is to determine what is the new area of your IOL orientation and assess the magnitude of rotation required and what would be outcome subsequently. If needed, take the patient for rotation. Ideally within a week. If bag is a consideration, high excellent, wait for at least 1 or 2 weeks. Use bimanual system, which is very, very helpful, and image guided system will always be better. So if I said here, more than 10 degrees, less than 6/9 visual acuity is a consideration, but if you're multifocal IOL, then visual acuity of 6/9 may not be appropriate. There, even for a small degree of cylinder rotation required should be done in these cases. Thank you for kind consideration. I hope this would give us some insight to our people to assess post-op period.
Thank you, sir. You have explained very beautifully, as I'm the discussant in this part. So my practice pattern for main port sealing is by manually approximating the 2 lips of the corneal tunnel with ironing by aspiration probe tip. While doing so, I keep the irrigation off. And if the AC collapses, I switch on the irrigation, form the AC, and again switch off the irrigation and do the ironing by aspiration probe. This way, it causes the inner lip to seal shut. And I further augment this closure of the wound by giving a supra-main incisional stromal hydration with the help of 30 gauge needle. And one more thing is that, sir, in case of flax with toric IOL, since we are doing from 2014, we have found that the flax capsulotomy is very weak. So in case of flax, if we have done a toric IOL, and if the patient is not very unhappy, and little bit of rotation is there, we should not go for the rotation, because this capsulotomy is very weak.
Dr. Bharti, your techniques are very good. They are quite strong as such. We have done surgeries, we have done a back fixation with iris hooks. Even that can be supported by these capsulotomies. Yes, if you had a difficult time, if they had some tags during your surgery, then that can be a little weaker capsulotomy. If your capsulotomy was good, that will withstand all the effective pressure which we do. And you have done a flax and you have done a multifocal toric, then you can't leave the patient like that. With a small degree of deviation also, these patients are very, very fussy and they demand very accurate alignment. Monofocal, you can leave it. I've left even a 10-degree rotation also, because the vision is around 6-9 or better. These patients can be left.
Can I ask something, Dr. Titiyal, sir?
Yeah, Nagendra, yeah, most welcome.
How do you ensure the long-term stability of the oil so we can have a very good
I didn't specify in our study, we had done a 1-month follow-up in these cases, and day 1 and 1 month picture was almost similar for all cases. That means if you have a stable lens at a day 1, nothing much will happen. If your lens is properly in the back, your axis is well covering the entire optic of the lens. The rotation or a lens, a little bit of decentration will only happen if your axis is not appropriate. You have an axis, one side covering, other side is not covering. So after, sometimes there'll be a toothpaste effect, and lens can be, displaced to one side. So that is the most common cause for late induction of a cylinder in these cases, because lens is, shifted to one side, and little tilt also comes in these cases. But if you have a good axis, good in the back lens, that means your surgery has been good. So late changes are very rare to have in these patients.
So does the incorporation of toricity on the anterior or posterior surface does have any effect on the rotation? I have come across this one study which shows that if you are putting the alignment on the 90 degree there, they tend to rotate. Yes. If you have a technique, it rotates anti-clockwise.
That's correct, Nagendra. Very well observed. I didn't go through it. It's in my slide also, it was there. If you have lenses which is with the rule requirement, that is 90-degree placement, people are documented that these lenses rotate little more than a horizontal placement. But I have not seen that personally from my side. And second is, you're right, all these technique lenses, they have a little more chance of rotation, because these lenses, they free rotate during your surgery also. These lenses can be rotated anti-clockwise, clockwise, both ways, while other lenses are difficult to rotate anti-clockwise. So what has happened with the study done by David Chang in recent time, they have modified the manufacturing of these lenses. They have not changed the design, but they have made their haptic with a little texture. So that is having a much more attachment to the capsular bag. Now, new study shows that rotation is almost similar to other lenses.
Professor Titiyal, please spare me 30 seconds, and I would like to talk about a situation out here. I would just like to take an opinion from you, and this is not related to the course subject for the day. One of my patients is doing fine with a toric implant in one of the eyes, which I had not operated, but the patient's vision is fine, but the patient has a very disturbing negative dysphotopsia and is just not going. The other eye also requires a toric implant. I think you know what the question is. So the other eye also needs a toric implant, and the patient is very firm in the opinion that I would not like to have the negative dysphotopsia in the other eye. So between doing a reverse optic capture in the following eye after putting in the toric and putting the toric IOL in the bag and putting a 0 power IOL in piggyback mode, which one would you choose, sir?
The first thing is, it depends. The first eye which patient is now having a negative dysphotopsia, you need to assess that patient carefully first. Either you have to rule out other important things which may be optically disturbing the patient, like a large angle kappa in these cases, a large angle alpha, which may be considered. Sometimes lens may be little decentered, especially towards the nasal side where the edge will come for a refraction. But if the patient is within a first month of surgery, the best option in these cases is, anterior reverse capture, because that's going to solve the problem. If the patient is, beyond the first month, where the lens is difficult to pick out from the, because what happens, it gets stuck. Then in those cases, we may have put a, piggyback 0 power lens, which might decrease the chances of negative dysphotopsia. And one of my students had patented a device. He puts a ring in the back in these cases.
The ND ring, yeah. Prakhyat's
Yeah,
ND
so
ring
that
is a good
also,
innovation.
that also decreases the dysphotopsia in these patients.
But I was asking about the other eye.
Yeah. So that is what would be a first consideration. But if patient is willing to go for other eye surgery before we do a correction of a left eye, sometimes after doing a second eye surgery, these problems decrease significantly because patient has a better acceptance. Other eye also, what we are going to do, we are going to do a rhexis, which is almost around 5.5. Don't make it too smaller rhexis because the capture becomes difficult in a post-op period. So if you have a 5.5 rhexis in these cases of toric IOL, the anterior capture is very easy. Small rhexis is very difficult, large rhexis never happens. So don't go beyond 5.5. So that might help. So there, I have done few cases where I had a little posterior capsular problem. Anterior capture can be done very easily with both types of lenses. The common lenses which have is either Akisoft or a Technis. Now we have Indian lenses also with the similar designs. Plate haptics should not be chosen in these cases. And don't choose hydrophobic also. Go for don't use hydrophilic. Hydrophobic and capture in this case. Definitely, I'll do a little anterior capture because this patient has the optics where going to have a negative dysphotopsia.
Thank you, sir.
Sir, what about the lenses?
Sorry, sir. Dr. Harsha, sir, you have anything to say? Otherwise, I'll go on to the next speaker because we are running out of time. No? Okay. So I'll invite the next speaker. Sorry, Dr. Bharti. We are running out of time. So yeah.
Chat box.
Yes, I'll
put a question there.
Sorry, sir.
She can put a question in chat box.
I'm putting.
Yes, sir. So I'll invite the next speaker, Dr. Sangeeta Kalita. She is working as an associate consultant in Cornea and Cataract Refractive Department of Sri Shankar Dev Netralaya, Bharthi. So over to you, Dr. Sangeeta Kalita. Dr. Sangeeta?
Yes, a very warm good evening to one and all present here. I'm very honored to be invited in this platform and to be amongst the stellars of ophthalmology. Is my slide visible?
Yes.
So I'll be presenting my topic on pearls for multifocal toric IOL implantation on behalf of Dr. Kasturi Bhattacharya Madam, as she was unable to attend this webinar. So in premium IOL surgery, we must hit the target refraction.
Sangeeta, can you go to the slide mode? Go to the slide mode.
Oh, okay. Yes, is it visible now?
Yes.
So in premium IOL surgery, we must hit the target refraction precisely. Even small amounts of astigmatism are detrimental to vision with a multifocal IOL. So the preoperative pearls for setting for implantation of toric multifocal IOL is, number one, to set a realistic patient expectations. Understanding the patient expectations and honest counseling of patient with regards to the expected surgical outcome should be done. Toric IOLs are universally recommended, as already spoken by other speakers, in cases with significant preoperative corneal astigmatism of 1.5 diopter or more. Patients undergoing premium IOL implantation such as multifocal IOLs may not tolerate residual astigmatism of even less than 1 diopter, and a toric multifocal IOL is therefore should be implanted. So next is ideal case selection. A thorough examination of the eye and precise preoperative diagnostic evaluation is needed to assess the magnitude and axis of corneal astigmatism. Now, we have to some contraindications for implanting toric multifocal IOLs are zonular instability, posterior capsular dehiscence, poor pupillary dilatation, and patients who have already undergone some prior vitreoretinal procedures, buckling, and glaucoma drainage surgeries, which may not achieve intended results with toric IOL. So the most important thing is the accurate biometry. And enhanced accuracy is obtained by measurements with at least 2 separate devices based on different principles, as already has been spoken by Dr. Deka. So axial length may be estimated by either ultrasonic biometry or optical systems such as IOL Master and Lenstar. Keratometry, we can go for manual and automated keratometers, but keratometers and Placido-based topography systems do not take into account the posterior corneal curvature. So Scheimpflug imaging systems and OCT measure both the anterior and posterior corneal curvature and are deemed to be more accurate. Highest precision for planning toric IOL power and axis was achieved by combining the keratometry and swept source Fourier domain OCT data. Now coming to intraocular lens power calculation, the ideal formula should take into account the surgical induced astigmatism, the posterior corneal curvature, as well as the effective lens position. Barrett's toric calculator takes into account all of this, and it has better predictability than the Baylor nomogram as well as Holiday and Alkan toric calculators. However, revised Acrisoft toric calculator incorporates the Barrett toric algorithm, and the Technis calculator also received FDA approval in 2016 to incorporate the posterior corneal astigmatism compensation. Intraoperative wavefront aberrometry is increasingly being used to estimate the toric IOL power and axis of placement based on the aphakic refraction, especially in post-refractive surgery cases. Now coming to the marking of the reference and the target axis, which has already been nicely covered by Dr. Pranita Sahai. So I'll just have a brief thing. So we have the manual marking methods like Newhan one-stop toric bubble marker, Buder-Garten pendulum marker, but manual marking methods have inherent sources of errors, such as smudging of the dye, irregular and broad marks. Moreover, they are associated with a significant learning curve, and intersurgeon variability may be observed in the accuracy of the marking. So then comes the image-guided systems such as Varian and Callisto Eye Aid. Now, Callisto Eye also assists in planning the position of the limbal relaxing incisions. Varian, on the other hand, allows comprehensive astigmatism management, wherein the surgeons can optimize the incision locations and toric IOL power as per their surgically induced astigmatism. Moreover, the position and length of arcuate incisions can be determined in cases planned for flex. Varian image-guided system utilizes the scleral blood vessels, limbus, and iris details as reference landmarks to determine the extent of cyclotorsion. Another system is the ITRACE system, which Titiyal sir has already mentioned very nicely. So ITRACE system uses the iris and limbal landmarks, and it can be used to calculate the location of these marks and their distance in degrees from the target IOL axis. Intraoperative aberrometry devices such as Optiwave refractive analysis and Hollows intraoperative Hollows intraop perform a real-time assessment of the aphakic or pseudophakic refraction to provide feedback for toric IOL alignment. So it is based on the principle of Talbot-Moyer interferometry. Now, cases undergoing toric IOL implantation assisted with intraoperative aberrometry are 2.4 times more likely to have 0.5 diopter or less residual astigmatism compared with other standard methods. Now, coming to intraoperative toric IOL alignment. Now, first we have to see that our corneal incisions are self-sealing, which are astigmatically neutral or induce minimal astigmatism. So self-sealing clear corneal incisions are most important. Then next is uniformity of the corneal incisions in terms of location and size is essential to prevent variations in the surgically induced astigmatism. Also, image-guided systems compensate for cyclotorsion and assist in the precise placement of incisions. Now here flex, well-centered circular continuous capsular axis providing adequate IOL coverage of around 0.5 millimeter is essential to ensure IOL stability in the postoperative period. So here flex come into account. So flex may further improve the outcomes of toric multifocal IOL implantation as well as both toric as well as toric multifocal IOL implantation. A significant decrease in higher order aberrations has also been observed with flex. The IOL should be left about 3 to 5 degree anti-clockwise of the final desired lens position. The final alignment should be done only after complete OVD removal and hydration of the wounds, as most open loop IOLs can be rotated only clockwise, and a complete re-rotation will be needed if the IOL rotates further clockwise of the target axis during these maneuvers, as Dr. Titiyal sir has already mentioned in one of the cases where 154 degree rotation was needed in one of the cases. So now coming to IOL implantation, now preferred procedure with all IOL with this kind of IOL implantation should be implantation under irrigation without OVD. Once the IOL is implanted, the surgeon only has to rotate the lens into the right position. He or she does not have to remove any OVD, which again could rotate the IOL. So implantation under irrigation, if possible, should be the preferred procedure for implantation of the toric multifocal IOL. Now, how to choose the IOL design? Now, for this, we have to take into account the diffractive technology comparison between the first generation multifocal, that is the bifocal, bifocal, then traditional trifocal, and the newer, that is enhanced light energy optical technology. So, if the bifocal, the first generation bifocal sacrifices good intermediate vision for better near and distance vision. So if a patient comes to us with, and if he or she needs a better or crisp near vision, then we have to take into account the bifocal, that is the bifocal toric IOL. If he needs a clear, crisp near image, then we have to take into account the bifocal toric IOL. Then in the traditional trifocal, the intermediate focal point of 80 centimeter is used to maintain the usable near vision. So if a person comes and if a person has needs a crisp, not crisp exactly, but if he needs an intermediate vision more than near vision, then we can go for trifocal lenses. And the recent one, which is the enhanced light energy optical technology, it redirects the light from the third step height to distance. It has a benefit of a more comfortable near to intermediate range of vision. It has a continuous range of vision from 40 to 80 centimeter. And the intermediate
you have 1 minute more.
Okay, intermediate focal point of 60 centimeter is there. Now, why near to intermediate range matters? Because the intermediate tasks are most often done at arm's length. And according to Human Factor Surveys and Occupational Safety and Health Administration, it recommends 60 centimeter for comfortable computer work. A continuous range of vision from 40 to 80 centimeter can help us deliver a patient's lifestyle expectations, which is computer work, smartphone use, cooking, reading menus, as well as playing games. Now, second benefit is the exceptional visual performance at every meaningful focal point. So as we know, enlightened technology transmits almost 88% of the light at 3 millimeter pupil size, which is unequaled by other multifocals. So 88% transmittance at 3 millimeter pupil size designed to provide crisp quality of vision at all distances. Now, this is a picture to show the crispness of the image between the Restore plus 2.5, Restore plus 3, and Panoptics. So now coming to halo propensity comparison, we all know that bifocals has less halo propensity than the other trifocals and the enlightened technology. So also this enlightened technology, it is less dependent on pupil size or lighting conditions. The smaller diffractive zone compromises near and intermediate performance in low light or in large pupil patients, and the larger diffractive zone compromises distance vision in mesopic condition.
Okay, Sangeeta, your time is up. Please wind up. Yes.
Okay. Okay. Thank you. Thank you. I'm just winding up.
Okay.
Okay. Thank you.
So, Madam Namrata is there? Okay.
I think she's in a different meeting of all in AIOS.
Okay, Dr. Namrata. Sorry, Dr. Saurabh Sharma.
Hi, Dr. Nathan. It's a beautiful presentation by Dr. Sangeeta. What I feel is that, like, I can tell from my prospect. I started with monofocal for so many years and monofocal toric, but recently I have started few cases of multifocal. So what I feel is that everything is included, but I still believe that if you want to start with toric, just go ahead with some of those practices in his routine cataract surgery. You can do a normal your aspheric lenses, and just you can make one your kind of one reference marking. You can make one target marking, and you can try the slit lamp, practice those cases, then you go to monofocal. And once you are good with monofocal, then you can think about all those new generation ATL like trifocals and all those things. Anyway, it's a beautiful presentation, Dr. Sangeeta.
Thank you, Dr. Sharma.
Anyone has anything to add?
Sir, Dr. Titiyal, sir, I have one question for you, sir. Sir, in one of my patients, sir, I had implanted a multifocal IOL in one eye, and the other eye, she is having astigmatism of around 2 diopter. So I would like your suggestion whether to go for multifocal toric. What would you suggest, sir? As of now, I have done only 2 multifocal toric IOLs, sir. That's why, sir, I'm asking you.
Definitely, if patient has around 2 diopter corneal cylinder, the patient has to be given a toric IOL.
Okay, sir.
Otherwise, the post-op visual acuity will not be up to the satisfaction. So if patient wants multifocal, yes, multifocal toric should be implanted. And toric lenses are like a routine lenses, routine surgery. It's not big deal that you're going to shift to toric lenses. So that's not a hurdle at all. And outcomes are very good. Even you have a 235 degree rotation, the outcomes are quite effective in these cases. So that's the beauty of toric lenses. I would definitely suggest you should counsel the patient for toric IOL implantation.
Okay, sir. Thank you, sir.
I think the segment of multifocal and trifocal torics is premium and of the highest order. So, when you are choosing your patients and asking them to go to that segment, one must make absolutely sure that every factor affecting the quality of vision is taken into consideration. We heard Professor Titiyal mentioning about angle alpha. I think if you have the machine to gauge the angle alpha, well and good. If not, at least you should look at the iris X and iris Y axis and their displacements on an IOL Master 700 or any similar equipment. If you don't have anything, also just look at the Hirschberg's reflexes on the corneal apex, just to make sure that they are falling within the range. Because when you take the patient to that top order premium segment, the patient would expect something in return too. So he or she should not be dissatisfied.
Yes, sir.
Very nicely pointed out. In toric lenses, apart from aligning the axis of toric lens, in a multifocal lens or a trifocal, you have to align the center of the lens also. So both has to be adjusted. So as you rightly pointed out, the coaxial light should be centered to the centermost ring of IOL. So that will make sure your lens is well centered. So both has to be centered.
Okay, sir.
Sir, where do you place the toric ADOF lenses which are going to come, like AIIMS, toric and all?
But they have not come yet, but I hope they will be giving us very soon. AIIMS lenses are doing wonderfully well for all our patients. So that's a welcome. My only consideration with all these manufacturers or people who have done R&D in these lenses, the cost of toric addition makes the cost triple, which is not justifiable. I've been debating with these people. You charge 10%, 20%. Why you make a lens 3 times costlier than your monofocal lens? That's absolutely, difficult for a patient to sometimes, accept. Your multifocal will cost something and it adds, another 50% onto that. So that I think we need to discuss with these people, I think the number of toric lenses have increased so much now. They should not charge more because the quantity has increased.
Very true, sir. To add on, I'm very happy with this trifocal practice and also trifocal torics. They give very good results. Patients are very satisfied, and I get very good wow factor from the practice. So I'm very much satisfied, and I also recommend everyone to not hesitate and go for it. Give the benefit of technology to your patients.
Sir, we are talking about 2-degree, 3-degree rotation. Now, rotation from the baseline. And if we look at the keratometry reading, we see there are 5 different keratometry readings, 72 degrees, 73 degrees, 74 degrees. So sometimes it is very difficult to choose which baseline will be the actual baseline, because suppose if we choose 70 degree, for example, and rotation, and the lens is placed at 72 degree, so that is 2-degree rotation, but keratometry was also showing probably 72 degrees. So I'm a bit confused, because to be honest, I don't bother with 5-degree rotation or so, because most of the time patients who are having 3 or 4-degree cylinder, they are quite happy with remaining 0.5-degree cylinder. So if you can just highlight how to achieve this 2-degree you are speaking
I think
about.
your point is well taken, because there are so many factors which can influence your outcome in toric IOL surgery wise. And one of the most important factors is the corneal cylinder, because that is the one which we are going to correct. So if you have corneal cylinder where axis is matching, as I said in the presentation also, if your axis is matching with 2 different instrumentation or a same instrument taken at 2 different times, if your axis is matching, then you are pretty sure if you're within 2 degrees, that's a good one, because it will never have a same axis coming all the time. And make sure you do a corneal power calculation or checking the corneal biometry in a virgin eye without doing any other investigation. If you've done something, call the patient next day to have a look on a corneal power in these cases. If you have a correction to be done for a small degree of a cylinder, as we are talking about 0.751 diopter, there little bit of deviation going to create a much problem to the patient. If you're doing for larger correction, suppose 2.53 diopter cylinder, the little bit of degree away will not make a huge difference to the patient. So if I have a patient who has more than 2 diopter cylinder, he or she is a good candidate, because whatever we do, patient going to be happy. Because I rightly pointed out the patient counseling factor. We'll never say I'm going to make you 0 cylinder, because that may not be absolutely true for every patient. So we are going to say we are going to make a cylinder which is less, which will be comfortable for a subsequent correction. So that should be our way to go for these patients. But you are right, if your cylinder power is not matching or a cylinder axis is not matching, 2 or things can be happen. Either the patient has a poor ocular surface, so that requires a treatment. Assess the patient for dry eye ocular surface, treat that patient for another 4 to 6 weeks, then assess. So sometimes the entire cylinder also go off with the treatment. The patient may not require a cylindrical power in a toric lens. So that point has to be checked. And make sure somebody who is doing the investigation should be experienced person. So that is also important.
No, I think apart from that, you should also check the keratometric points where the machine has taken them, and then see whether all points have been marked with dots. Not a single point should be marked cross. You should cross check how good, how qualitative are the points from where the readings have been taken. And if you have more than 1 instruments to use, then you must have a go-to instrument whose keratometry you always trust. So that's also important, be it the 700, be it the Varian, be it the Anterion, whatever. But you must have one go-to instrument in case of a dilemma or a doubt. You should trust the readings of one particular equipment.
Okay, another question. If you have a patient who is, say, -2 cylinder at 90 degree and gives a history of never wearing glasses in lifetime, so probably he or she is using her toricity to do the near vision. In those patients, shall we advocate toric or shall we try to leave them with the minus cylinder at 90 degree? Because they will be very unhappy once they lose their reading power.
No, two diopter cylinder is actually not helping the patient for getting a little bit of a depth perception, which normally happens with against the rule astigmatism, with the minus cylinder 90 degree. In such cases, what we do, you don't overcorrect the patient because you're going to take away the cylinder from patient. So little undercorrection is desirable in these cases. But if you look into posterior corneal curvature of all patients, normally they are at 90 degree minus cylinder. So if you do a little more undercorrection, you're going to leave more cylinder. So make sure you take a consideration of posterior corneal curvature in all patients who have, with the rule astigmatism. If it is against the rule astigmatism, it may not make a significant difference. For this patient, I'll make sure that I leave around 0.5 cylinder. So the patient would use that cylinder for a subsequent outcome. It will give a better near and it will also give a little more depth perception. 2 cylinder is too much for a cataract surgery, patient undergoing cataract surgery.
No, sir. And Dr. Shogoto, when we are removing this, having this -2 90 degree and we are doing a cataract surgery, his near vision is already gone. You have to add on it, no way out.
Yeah. But leave little bit of minus cylinder 90 degree. That will help the patient because patient is used to that cylinder for a very, very long time.
Yeah, only that part can be correct.
Yeah.
Yes.
Yeah, that's what I'm asking. Also for the juniors, I think we sometimes when we get a cataract patient, after going through all the tests, we rush the patient through to biometry and then select toric. So it is very important for juniors to remember that it is better, always better to call the patient. If we get a cylindrical power, always better to call the patient and repeat the biometry when the patient's eye is fresh, hasn't gone through drops, dilating drops, hasn't gone through IOP checkup, because all these can give erroneous keratometry reading and can give rise to dissatisfied patient at the end. So for juniors, they should be very careful while selecting these toric patients in this way.
Dr. Sugoto, just an expansion to your thought, one must also be mindful about the lens tilt that I had talked about earlier. Of course, 2-cylinder is not something that the lens tilt normally compensates for.
Yes, yes.
But still, if the patient does not have any history of wearing glasses ever, you might just think that the corneal toricity is being negated or is being neutralized somewhere else. And the lens tilt is a very important factor there. So one just has to be mindful about that.
Okay, before we come to the conclusion, may I request Dr. Titiyal sir to give the last comment, overall comment for everyone.
Last comment from my side is, congratulations, wonderful session we had, and it's nice to see that so many of my old friends are there. We have been together for ages. I'm so happy to see, Madam Jennifer. She's been so kind for inviting us to a beautiful place, Shillong. And unfortunately, with this COVID prevalent, cannot visit your place. But in future, definitely, I like to visit your place again. And seeing Harsha
sure,
and
we'll yes.
and I'm seeing Harsha and Dr. Ranjan and Bharthi.
Yes.
And it's so nice to see. And Sachindra is there. I hope things are all right in your place because Manipur is doing quite okay. No, not many cases. In that way, entire eastern part is better than Delhi. Delhi is going through a difficult time. But whatever said and done, academic society, you people are doing wonderfully. I keep listening to whatever things are being happening. And today's topic chosen was very nice. Toric IOL, people have a mindset that it will be difficult. What will be outcome? How surgery is going to be tough? But we know that it's not tough. It's very simple, and outcomes are very, very good for yourself and for patient. As rightly pointed out by all of you, that patient satisfaction is a prime thing for us. If patients are satisfied, you are going to be there for a long time for benefit of society. So wish you all the best and hope that you invite me for a subsequent future webinars also. And I'm so happy to see, my students, they have become teachers now. Panita doing such a wonderful talk today. And see Natung, Sachindra, so good. I think it gives you goosebumps seeing these people doing so well, and hope that they keep the flag very, very high.
Thank you very much, sir, for your kind comments. So, this astigmatism management is a very a favorite subject to me, so that's why I had chosen this topic.
I have one suggestion, Natung. You should post, this after making compiling this talk to entire members of your society, and ask, you put up some format questions. You can do a survey of the things, what you do based on a two-day thing, and get a survey results maybe after a few weeks, and discuss that subsequently in some of the webinars.
Okay, sir.
That will be wonderful.
Normally we record all the webinars, and that is circulated in the eastern part of the country, sir. This time we'll circulate it at the all India level, sir.
And you take a survey also from your people, what have been their practices, and that will also show you that, what has been the impact of your this webinar subsequently to this.
Yeah, I strongly feel that everybody should be doing Toric IOLs.
Yes.
Yes, sir. So, sir,
before vote of thanks, there is a small video clip by entered people.
Okay.
Mr. Rahul Jain, can you play the video, promotional video?
From my side also, personally, I want to thank President Sir, our Secretary, and our Scientific Chairman, Scientific Committee Chairman, for giving me this opportunity to organize this webinar and reposing faith in me. Thank you very much. Now I'll invite Amar Chagma, his non-figure, to all of us. I'll request him to give the formal vote of thanks.
I haven't heard anything from Harsha. Who's Harsha speak? I have seen him after a long time.
Yes, I gave him this chance. Sir, if you want to say something.
You have to say something, Harsha. I haven't seen you for a long time.
Sir, he is with the mask on. That is why he is not speaking, sir.
Sir.
Sir,
You have to unmute yourself, Dr. Hassan.
Sir, we are online, so you may remove your mask for some time.
Don't worry.
Can you listen now?
Yeah, I can
Yes,
hear
sir,
you.
we can hear you.
It's
Okay.
nice seeing you.
Now I am listening very carefully. The entire discussion and the new technique, what we are regularly doing. But from the academic point of view, I find the dynamics of astigmatism is completely different. It starts from the cornea and ends with the retinal astigmatism. So I think this technology miles to go to achieve perfection. And that's why we see the changes of all the models and other things. But so far, so good. I think we have to think in a many newer dimension to achieve the 100% perfection. Because we know that there is a diurnal variation of the refraction and other factors which are yet to be addressed. So this is my personal viewpoint. Thank you.
Thank you, sir, for your nice comment. So, may I invite Dr. Amar?
Yes, sir. Yes, sir. Good evening, my respected colleague from IJOC and other parts of India. Feeling extremely happy to see you all in the midst of COVID pandemic. First of all, I take privilege to wish you a very good health in the auspicious World Health Day 2021. I am very much thankful to IJOC for allowing me to say a few words in front of my senior and respected colleague. At the outset, I extend my sincere thanks to all the speakers, chairperson, and our special guest, Dr. Titiyal sir and Namrata Sharma ma'am, for taking out some time and to say and share their experience with us. I also take privilege to thank our esteemed from Northeast and IJOC in the discussion. Because of their expert opinion, the forum is complete with full of inputs, and our audience got much more clear view on the subject and the topic. I really feel proud and thankful to our present office bearer of IJOC for creating such a good platform for interaction and discussion for the people of IJOC and connecting with rest of India with sharing of good quality knowledge. IJOC feels proud to felicitate its one of senior member, Professor Satyabama ma'am. Thank you, ma'am, for giving us time and to be among us in this virtual meet. Last but not the least, credit goes to Dr. Natung sir and his coordinators for choosing a beautiful topic and taking pain to arrange such a beautiful meet in such a short time. IJOC, particularly Northeast, is very much thankful to you, sir, and your team. At last, the speech will remain incomplete if we won't take name of entered. Organizing committee is very much thankful to your firm for helping us to arrange this virtual meeting. Thank you, everyone. Good night. Stay safe. Thank you.
Thank you very much. Thank you, Amar.
Thank you. Thank you, everyone.
Yes, yes.
Thank you.
Thank you.
Good
Thank
night,
you.
everybody.
Bye-bye.
Good night. Stay
Bye
safe.
bye. Thank you.
Bye.
Take all precautions, and we sign off for the next month. We'll meet next month again.
Thank you.
Yes.
Thank you, everybody.
Thank you,
Good
everybody.
night.
Thank you.
Vijita.
Thank you. God bless. Thank you.
Thank you, everyone.